I'm happy to introduce myself. I'm Patsy Brannon. I'm a visiting professor at Cornell University following my retirement from being a professor there for 19 years. It's really a pleasure to be here with you today. I want to thank the organizers and the Food Nutrition Board for inviting me and presenting me this interesting challenge to integrate, reflect, and share my reflections with you on this workshop that has been broad, deep, nuanced, and highly informative. And so the approach that I'm going to take today, if I can figure out which button I push. Okay, the little thing? The big triangle. The big triangle. Aha, got it. I want to remind you of the context that was set out for us yesterday morning at 8 o'clock that differs today. And we know that, and this has come up over and over and over again, moms now are older, fewer adolescents, fewer smokers, more overweight, obese, and diabetic, and more excess weight gain. Births now are more preterm, but also more term and more low birth weight. And there's been a shift in the dietary patterns and food values so that there is more intermittent fasting, more paleo, low carb, and other restrictive diets, we might call them, and more values on organic, natural, and sustainable foods. So within that context, what I'm going to do first is talk to you about what are some cross-cutting themes that have come to me as I've sat and listened. And you need to know that my filter is as a nutritional scientist interested in molecular nutrition and engaged in discovery research during my career, but also engaged in translational research and policy development. And so I have really appreciated the full continuum of the translational research model, from discovery to clinical interventions to broader interventions to public health program evaluation. And I think that's been a real strength in this workshop. One thing that's very clear is that there is new evidence and emerging issues since 1999 and 1991, surprise, when the last reports came out. And these issues run the gamut of protein, energy, particularly relating to obesity, but not exclusively, type of carbohydrate, one carbon metabolism, micronutrients, other micronutrients, the developmental origins of health and disease, abbreviated here as DOHAD, obesity, GDM, dietary patterns, and how do we engage communities and individuals in their setting to ensure that they achieve optimal nutrition and pregnancy outcomes. So as I've listened to this, one of the themes that came out clearly to me was the issue of biomarkers, particularly in the context of physiological adjustments, not just exclusive to pregnancy, but also present during lactation. And we can think of the nutrients for which these issues have come up. Either there aren't biomarkers, or we don't know what the appropriate cutoffs are, or it isn't clear how to interpret the data in the context. And this includes omega-3 fatty acids, iron, vitamin D, folate, especially for high status, choline, vitamin B12, antioxidant nutrients, and iodine, both in pregnancy and lactation, and the biomarkers differ. We've had issues that relate to supplements in terms of dosage, form, bioavailability, timing, but also in terms of to supplement or to eat foods. And the issue of quality diet and quality dietary patterns has come up over and over and over again. And we've heard today a number of speakers talk about diet is the preferred way to approach this. And the issues of form and bioavailability are equally important in quality diet and dietary patterns. So things to think about. We've also heard about consistent theme for a number of nutrients of the interaction between status of the individual at baseline and the interaction with supplements. These issues came up for omega-3, fatty acids, folate, vitamin D, iodine, energy, and antioxidants. And the U-shaped risk was very clearly evident. Those with low status likely to benefit, depending on the outcomes. Those who are adequate or replete, you may not see a response. Those who have high status may be more at risk for adverse effects. And we think about the heterogeneous populations that are often in our studies. It's no wonder that we sometimes get negative results because we averaged those with low status, those with adequate status, and those with high status. And so it can become difficult. Another cross-cutting theme that I found very interesting was this notion of the continuum of what we might call reproductive success in terms of preconception, pregnancy, postpartum, and lactation. And we've heard about our healthcare system sort of puts us in silos. Our intervention programs, with perhaps the exception of WIC, puts us in silos, and this is not serving us well. And so that's a cross-cutting theme that interacts with virtually all of the other issues that have come up in this workshop. I want to talk about developmental origins of health and disease a bit. One of the intriguing issues were human milk oligosaccharides, including fructose, which the last time I checked was not an oligosaccharide, but still has bioactive components, as we heard. And these are modified by diet, maternal dietary fat and carbohydrate, and they affect the microbiome, growth, body composition, and brain development. And these are issues where there's potential for intervention, but also the need to understand what are the specific effects of specific human milk oligosaccharides. And what hasn't come up is there synergy, and I raised this question with you, synergy among the mixture? Small amounts of a variety of foods. Sounds like bioactives, doesn't it? And so we also have heard about themes around obesity, gestational diabetes mellitus, nutritional status, altering placental function, and its direction of both the mother and the fetus, issues of these same factors in terms of lactational performance to program the microbiome, chronic disease risk, DOHAD, and the stress response. And the issue has been raised about sexual dimorphic responses of fetus and placenta to maternal nutrition, obesity, and GDM. So the situation is very complicated just in looking at the pregnancy milieu and the lactation. We can't just talk about maternal infant diet. We've also got to add the placenta in there because it's not a passive participant. And I think that's an important issue to keep in mind as well. A cross-cutting theme that I've reflected on a lot here that hasn't necessarily been articulated yet is the issue of chronic disease outcomes and expanded DRI model. And I want to talk about this because it has great implication for selection of outcome, for specifying DRIs for adequacy and chronic disease risk reduction and upper level, but also the nature of the evidence that's needed. And it's something that as we move forward as a community with additional research, we need to be mindful of what is going to be the level of expected research quality to be able to specify DRIs in the new model. So one implication that is lost sometimes is that with the advent of a chronic disease risk reduction, DRI, if there is a chronic disease, that is the DRI that has to be specified. If the level of evidence rises for a selection of a chronic disease outcome, it's a CDRR that will be specified. And this also means that for the EAR and the RDA, an adequacy outcome is required. You cannot use a chronic disease. We have AIs and had we've had AIs based on chronic disease outcomes, fiber and sodium before its respecification this past year. And that will no longer be. And think of the difficulty. If we lack biomarkers that we can interpret and set cutoffs to tell us whether a nutrient status is adequate or not, what kind of adequacy outcomes are we going to use for those nutrients? And I gave you a list of a lot of those nutrients. There are also the issue for toxicological outcome is now required for the UL. No longer can you use a chronic disease outcome indicator. And the level of evidence that will be required if a chronic disease outcome is selected is moderate, not just for the linkage of the outcome with the status of the nutrient, but also for the dose response. And a CDRR could not be established for potassium, not because it wasn't an outcome indicator, but there was not moderate evidence for dose response. So these are issues that we need to think about, particularly in the context of what we've heard over and over and over again about inconsistent or discordant observational evidence and RCT results for many nutrients and chronic disease-related outcomes. These include vitamin D, antioxidants, omega-3 fatty acids, particularly related to the immune system, challenges in synthesizing the evidence, and inconsistency of results that arise from variability in study design, in dosage, in timing, in baseline status considerations, and in biomarkers. So the body of evidence is going to need some attention from us as we're designing our studies and we move forward on these important questions. And developmentally validated surrogate endpoints are really going to be critical. And I raise this because, especially when we talk about DOHAD, we're not going to be able to wait 30 years for the chronic disease incidence. And one of the issues we're doing right now is using endpoints, surrogate endpoints, that may have been validated in adults, but have not necessarily been adequately validated in the developmental periconceptual to lactational period, and will need to be that will need to be done, I believe, in order to be able to use such surrogate endpoints. Other cross-cutting themes in terms of disparate outcomes, status, and intake, especially for at-risk populations. And we've heard at-risk populations described in a number of ways for many nutrients, for the use of supplements, for the quality of diets, and these include lower income and education, multiple fetuses, obese and overweight individuals, that says pre-gravid, but that could also be postpartum, non-European, non-Hispanic Black individuals, those with unplanned pregnancies, adolescents, younger individuals in terms of compliance with supplement use, vegans, and those excluding gluten from their diets. We've also heard in the last session issues that relate to social injustice, stress, obesity, gestational diabetes, poverty, food insecurity that drive these disparities. Social injustice was named as a primary underlying factor, but each of these then interact, and they may stem from social injustice, but they are each important in their own way. And we focus interventions, I should say trials, on reducing stress response. There's some evidence for doing that. So not all of our interventions need to be nutritional in nature, and that needs to be kept in mind. And WIC addresses vulnerable at-risk populations, supports improved breastfeeding inequities and nutritional risk, and is an example of a program where we have considerable evaluation and broad spectrum impact. And I want to focus on the cross-cutting theme of systems approaches. We heard about this in the discovery research, but I thought it was particularly important when we heard about it relative to program evaluation and making a difference in what we might term the real messy world. And the importance of informing this in terms of implementation science and the need to improve food and physical activity systems and reduce food insecurity in order to have optimal pregnancy and lactation outcomes. I want to move from these cross-cutting themes to some of the issues that we have. I have about 5 minutes left. I'm going to hit some highlights. I'm not going to cover everything on each slide, so bear with me because I'm going to have speaker-selective editorial privilege. Omega-3 fatty acids, there's certainly a large number of trials. There's evidence of decreased early and later preterm birth, primarily with fish oil supplements, and to some extent in diverse populations in signal-clone pregnancies, but there's also evidence for, at high levels, prolonged gestation. And this raises the issue of the balance of U-shaped risk. There's conflicting evidence on allergies and asthma, and little evidence of clinically meaningful benefit for a number of other outcomes. In terms of protein, newer, more precise, stable isotope approaches demonstrate that higher and also a dynamic requirement may exist than the current DRI, and this is based on quality protein. And energy-balanced protein supplementation is important to consider, but also we might be thinking about what quality diets look like, not just in terms of protein as a percent of energy, but where the protein sources are coming out. And we've talked about education. We have many people, and it's been spoken to, adopting a vegan diet who don't understand what complementary proteins are or how they can achieve this within their preferred dietary pattern framework. In terms of carbohydrate, both the type and amount and quality are important, and there are a variety of issues that have been highlighted for this, and evidence of, but the evidence of type and quality of carbohydrate and low glycemic index in terms of chronic disease risk is limited. Folate is clearly important, and the success of mandatory folate fortification in reducing neural tube defects is evident, but our preconceptional compliance with folate supplementation is low. The long-term benefits of folate supplementation are beginning to be explored and are important. As we look at emerging evidence on low B12 status, also associating with maternal gestational diabetes, preeclampsia, and neural tube defects and other pregnancy outcomes. We heard evidence on the importance of choline and supplementation during pregnancy to reduce neural tube defects and the stress response and other risk factors and infant outcomes, particularly cognitive. The theme then about prenatal supplements not including choline is an important one, and the issue of how dietary patterns can be structured to meet the choline need is one that needs some attention from us. Iron we know a lot about, and even as much as we know, the preponderance and the synthesis of the evidence says, and I want you to listen to this, the best we can prove with iron supplementation is maternal hematological indices improve. Anemia is reduced. But the linkage of that to pregnancy outcomes is considerably less certain, and that's an important issue for us to think about. The prevalence of iron deficiency anemia in pregnant women in North America is relatively low, even though many pregnant women conclude pregnancy with low iron stores. And there are issues of the applicability of the cutoff points that we've talked about. Vitamin D, metabolism adapts, and there are issues then about maternal supplementation. It, again, improves maternal and neonatal circulating 25-hydroxy-D levels, but it's less clear how that relates to reduction of risk for chronic disease or improved pregnancy outcomes. Calcium, I'm going to skip. Antioxidant nutrients have certainly been raised as an important issue, but again, we have discordant evidence of associations with pregnancy outcomes and randomized clinical trials. And the observational evidence that associates vitamin E status with congenital heart defects, and that's high vitamin E status, merits further attention. In terms of iodine, there's been a lot of discussion today, and low maternal iodine associates with impaired cognition and verbal skills and autism in offspring, and we are seeing more issues around that. The dose response, however, the evidence is low to moderate, and iodine supplementation is recommended. We've talked a lot about diet versus supplements, and a number of times we've talked about iodized salt as a model of food fortification, and I want to play devil's advocate with you. So what would happen if we thought outside the box? And if, in fact, we're sending the message to everybody, reduce the amount of sodium that you eat, but then we want to tell pregnant women, no, 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 keep using that iodized salt shaker. Isn't it time we thought about what else we could fortify with iodine that would work? Do we have to keep putting it in salt? Just a devil's advocate issue for you to think about. So I want to talk a little bit about dietary supplements. We heard that they're helpful in helping pregnant women and lactating women not meeting the UL. There are issues around standardization, and there are issues around bioavailability and characteristics. We talked about decreasing caffeine as a strategy of optimizing fetal growth, but it's challenging to assess intakes. We saw that human milk oligosaccharides, which we've talked about a bit before, have beneficial effects, and that needs to be explored further. We also talked about human milk content of some vitamins and minerals can be improved by improving the maternal diet, although it's not clear that supplementation will have the desired effect. And key evidence is emerging on analytical approaches that help us look at this, so we may have more information. And maternal obesity and GDM are strongly related to adverse effects in lactation, including lactational performance and altering human milk fatty acids and other human milk factors that regulate appetite, energy, and body composition. And lactation reduces the risk of maternal diabetes later in life. We heard a lot about the role of the placenta in DOHAD and the importance of this and the interaction of maternal nutrition type and level, as well as obesity, gestational diabetes, oxidative stress, and other stress factors in terms of long-term health adverse consequences. And we heard about the strong inequities that exist that relate to social injustice. Poverty also induces stress and impairs nutritional status. And we have a need to understand ecological and social factors across the life course and to have frameworks that relate to these factors. And as we think about the programs we're having, implementation science and informing this science with models that allow us to think a systems approach across diverse systems is important. We also heard about food insecurity and its relationship to stress and its influence on nutrition. And we heard about WIC and its model programs. So with that, I apologize for going over, and I'm going to open this up now to you to come to the mics and say who you are and talk about cross-cutting themes or important issues that also struck you from this workshop, your reflections.